So this morning, we are going to address the ACGME general competencies of patient care, medical knowledge, professionalism, system-based practice, practice-based learning improvement, interpersonal communication skills. Palliative care covers it all. And today we'd like to provide an overview of pediatric, palliative care, and hospice philosophies, and some of the resources that our faculty and community partners can take advantage of. This is still a very young field, so I think it's going to be important for folks to understand how pediatric patients can make use of palliative care at UCLA and hospice care through institutions such as TrinityKids Care, which is really the only pediatric specialized hospice in Southern California, and to learn how we might apply palliative care to our own practices and the way that we view working with our patients. So we'll talk about palliative care. I'm going to invite Roy Cow up to speak about a patient that we're currently talking about in our rounds and providing care for. And this patient is also receiving care at TrinityKids Care-Hospice. So I think we'd like to talk about this patient later on today as well. And then I'll come back and talk about our program and where we've come, how we are doing today in this day and age, since our program is still fairly young in the UCLA health system. And then invite our guest speaker, Dr. Glen Komatsu, to take it from there. Palliative care. The definition of palliative care actually changed in 2002. So it's still a fairly young field in terms of this new concept of what it is. It used to be seen as an either-or approach, and I'll show the famous diagram. I use these 2 slides for every single talk, and I've given it to other faculty who really feel like there needs to be some education and understanding, because we have to remind folks about this new culture, that it's actually a field of prevention. We want to assess and identify symptoms related to suffering early on in the disease course and provide treatment of pain, other problems, physical, psychosocial, and spiritual, before things get exacerbated. So the top model over here is this old model of palliative care, where we would provide curative treatments until we could no longer find a cure, and then provide palliation, so pain and symptom management until the death of the patient. But now we have this new model of palliative care, and I add in over here prenatal care, because a lot of times through genetic testing, we know that the fetus has a life-limiting condition. And so what kind of resources can we provide to this family to give them opportunities and options for care once they, if they decide to have this child, and how to care for the child. And so it is this concurrent model of disease eradication with pain and symptom management, quality of life planning, in anticipation that there might be bereavement. And I say this, there might be bereavement, because we're at UCLA, we're in a medical center that we do have a curative approach. We're a major tertiary care medical center, and we are a big transplant center. So palliative care can be introduced at various stages of the disease course. During transplantation, when we're waiting for a transplant, if there is rejection of the transplant, during retransplantation, and even if there's adherence and this child has a long life, they still could benefit from palliative care. And so there are many opportunities for palliative care. There's also this concept, I look at this as a fried egg. It looks like an egg to me with the yolk in the middle. This concept of palliative care is this overall concept. And then hospice is a part of palliative care. Hospice is, and I'm going to let Glenn talk about that later, but just to kind of give you an overview, that hospice is provided usually at end of life, but now with some of the new legislation that we've been working on that actually is now being used and implemented, we can provide hospice along with palliative care, because it used to be an either-or model, and Glenn will talk more about that later. So I want to invite Roy up.
Thank you, Elana. So actually, what Elana's comments had brought to mind for me was a quote from a patient that says, palliative care isn't about dying well. It's about living well until that one day when you do have to go. So a lot of this is really about living well. So I wanted to introduce patient O. So just as a way to introduce this topic and get our minds thinking in terms of a clinical way. So he's a 21-year-old with recurrent metastatic Ewing sarcoma. He had an original cancer diagnosis in 2010 in his kidney. He had resection chemotherapy. He had another recurrence with a liver lesion. He had radiation. He had more chemotherapy. He was off therapy for a year, and then he had another recurrence. This time it was kind of more outright spread with left femur, right iliac bones, ribs, scapula, liver. He got more chemotherapy. Other lesions were stable. He developed, got more chemotherapy, got progression of disease on that chemotherapy. This was his progression of disease. So you could see femur, iliac bones, lung nodules. Eventually went on a PARP inhibitor trial, which also developed substantial increase in most of his lesions, and currently he's still on chemotherapy. So that's kind of his treatment summary. And in terms of what we look at as major symptoms, which are bone pain, neuropathic pain, secondary to some of these metastases, is poor sleep, secondary to pain, history of anxiety, nausea, mucositis with chemotherapy, and also some sedation secondary to some of his other medications. So that's kind of a clinical summary of him. But what about him as a person? I think that's really an important thing to bring out. So this is our patient O. He has a book. He's engaging, he's positive, just thinking of all the different adjectives that I described, and he's super open, receptive. Michaela, our nurse practitioner, calls him a survivor in every sense of the word. He always asks us how our team is doing, not just which patients ask you how you're doing. In terms of family, friends, and faith, those are really, really important to him. He keeps a blanket from members of his church, and each thread is stitched with a prayer from each member of his church. And this is a quote from his book that just shows you how important his family is, and what he says that his parents bought a new house before he was diagnosed. They came to Mexico when he was a child. When his father was a child, they lived in a one-bedroom apartment, and then they basically fought their way up to the American dream. So that gives you a little bit of a hint. So I asked him, what does quality of life mean to you? And so he said, knowing that he's still doing all he can to fight the cancer and cure it is really important. And the reason is that he doesn't want to miss out on time with his families and his sisters and his friends. And he says he wants to live life to the fullest and live day to day, despite any side effects. So our team's goals have been managing his symptoms, giving psychosocial support, and working in partnership with Glen at TrinityKids Care. So I wanted to turn it back to Elana.
As you can see, we use a team-based approach. Roy is, we're grateful to have him. He is new attending on our team, and we'll talk more about our team process. We've come a long way, and so this is the state of affairs of palliative care. We started in 2004, and it was Lonnie and myself, really. And we have a thriving, developed chronic pain research program, so I want to put that out there. This talk is on palliative care, but that program was well developed and way before I came along, and we started developing this palliative care program that we have today. That there, Dr. Zeltzer, who's been a mentor to me, has been a mentor to many people in this field, has started this field of chronic pain, and is our current director of the overall program. So I just wanted to mention that. And we've been starting our clinical inpatient service since 2008. And then we recruited Gina Kornfein, who's sitting in the front row, to initiate and start a bereavement program. And we'll talk a little bit about that. So we're a young program in a new field. And these are just some pictures of our team, because it's taken a lot of teamwork. From starting off with just Dr. Zeltzer and myself, we've grown, and we have a lot of supporters. We had our first 5K walk, and as you can see, a lot of family and other folks, Justin Seffens and his family, and even a dog. So we take all the supporters that we can get, and it's just been a really nice opportunity. So Dr. Zeltzer is our overall director of our Pediatric Pain and Palliative Care program. Myself, that is the director of program development and research. Julianne Harrison, who is one of our attendings, and Roy Cow. Michaela, who is the core, really, of our inpatient clinical service, and our nurse practitioner. And Gina Kornfein, who is our social worker and director of the bereavement program. Nancy Torres and Michelle are in our office, and Irene and Johnson, who is a chaplain who helped us with building the program, and Kelly Carroll at Child Life has been a wonderful consultant. So to kind of go back to this concept of palliative care and how we integrate that at UCLA, it is a focus of relief on suffering and achieving the best possible quality of life for our patients. We work alongside the primary treating team. So part of my fellowship in developing this program was going around to different hospitals around the country, spending time at TrinityKids Care-Hospice with Glen's team, and really learning from them and other model programs in the country about how to develop a service that's appropriate to the culture at UCLA. So we don't overtake the care. We're sort of the behind-the-scenes person, and that's sort of how I see my role in the team. I'm sort of the behind-the-scenes person working with our clinical team. And then we work to alleviate pain and other symptoms. And it's a constant assessment and reassessment of symptoms because they change throughout the disease course. We aid in decision-making, and we help with establishing goals of care of treatment. And that's going to overlay into some of the other initiatives that are going on in the hospital, which I wanted to talk about briefly before I turn it over to Glen. And we also provide psychosocial support. We assess caretaker function and support and communication, and that's a lot of the research that I'm doing right now, which I'll refer to later. And it's offered again with simultaneously with life-prolonging and curative therapies for children with critical illnesses, and bereavement care, which is a huge piece of what we do. So I'm gonna actually refer to Ashley Malabanan, whose mom was interviewed by our team, and who talks about her daughter who was on our service and how she found Comfort Care to be helpful to her.
Although she expected it, it was very hard for her to accept it. She needed time to process her feelings. She needed to talk about it, to process it, to plan for it. But she kind of felt like she didn't have that opportunity. I kind of wish that she had somebody to talk to.
I just got my laptop fixed.
How did yours fit?
Mom, you're in the middle of my video. And I just got my laptop fixed, and now I can make videos. Everyone applaud. Come on, Mom.
When the Comfort Care team came aboard, I thought it was really nice because it gave us opportunity to talk about what we can do for Ashley during her last stages of life. and we talked about how much quality of care meant the most to her. And so the Comfort Care team was able to help us to meet her goals, to grant her wishes, to be in a place where she could be comfortable during her last days.
So Jeannie really talks about this idea of early referral. She didn't have enough time, according to her mom and Ashley herself, to process a lot of what she was going through. And so this is one of the challenges that we face today, this concept of early referral, and that and also demystifying some of these stigmas and what we are about. So we've actually, because of some of these challenges that we face, we've actually increased the number of ways that you can consult with us and use our service. And, paging us, email, calling, we use telehealth. That's a big thing that we're piloting right now. And just stopping by our Comfort Corner on the 3rd floor of Ronald Reagan. And this is how you would contact us. So I talked about early referral and planning for end of life. A lot of the comments we get is our team is not ready to talk about that, or we're not ready to go there yet. And so we offer that support. It doesn't mean with a consult initially, but just bringing the case to our attention so we're aware of it, and we can provide different languages to be used in order to introduce what palliative care is, or just to provide another source of support. One of the other issues is that we have trigger consults now. Every BMT patient receives a palliative care consult. In fact, most every patient here at UCLA Medical Center could get a trigger consult if they are in the PICU for a certain number of days or whatever it might be. One of the issues that we have are limited resources, which I'll talk about at the end. And this whole concept of communication, and how do we communicate about palliative care? A lot of times I am asked to give lectures about communication and language, and what are the best ways to introduce palliative care? How do we decipher the kinds of things that may clue us into a patient's suffering? Or how do we decipher who to speak to about certain things within the family system? So this whole concept of miscommunication and multiple subspecialists, this is what palliative care teams do. We spend a lot of time bringing together the multiple teams that put their life's work and their hearts into taking care of their patients. With these very complex patients here at UCLA, palliative care is necessary for almost all patients. And this concept of parents as a proxy reporter, this is data and research that we've collected and have published and continue to work on and publish. But this concept of concordance, that in the pediatric population, we're relying a lot on what parents say their child's experiencing, and their experiences of stress, anxiety, their pre-morbid or before the child's illness way of coping or talking with their family all affects the way that we talk about these things. And then the symptom distress of having a traumatic illness, a life-threatening illness. We also have this concept related to calling a palliative care consult of the fact that this is perhaps an end-of-life service. Yes, we do deal with end-of-life issues, but most of our consults are not end-of-life. In fact, we do a lot of goals of care planning, symptom and pain management, which our physicians, our expertise are in that area. And that all we do is talk about death, which is not true. I think I can recall maybe 2 patients that asked Dr. Zeltzer, what is it like to die? And sometimes painting that picture can be very, very helpful to families and to kids. And this concept of, we call a palliative care consult, we're giving up. How about reframing that and saying, calling a palliative care consult is another resource, another opportunity to provide comfort to your patients. And this idea of that it is a new field. We are still developing the science behind the field. There are limited trained professionals in this field. That's why it's so hard to recruit folks. And so we were trying to grow our own clinical team by starting a fellowship, by doing all these things that our chair and development have been in support of us doing. And the fact that we are small teams and we can't be in multiple places at the same time, so using patient and healthcare provider friendly technologies like telehealth. And obviously funding is a huge issue that we continue to work on.
So Ashley is the type of person that if she trusts you and she feels that you're able to help her, she'll open up to you and let you know what she wants. She wasn't shy about letting you know what she wanted, how she felt about things.
Hi, my name is Pebbles, and this is Fred Flintstone.
I think Ashley was able to grasp onto to your team because your focus was on her. Focus on making her feel comfortable while she was at the hospital.
So Jeannie talks a lot about, in a lot of detail, about how we were able to make Ashley feel comfortable, and this concept of letting the patient lead the way and lead the path. And I know Glen speaks a lot to that, and he's been a mentor to me in that way, in terms of whole person care. And the fact that it's so important to know how people cope and how they want the information to be presented to them. And Ashley was very well aware of it and wanted her team, her healthcare team, to know that too. So along those lines, our current research and program development lay along the lines of symptom communication, psychoeducational interventions, and so that's something that I'm heavily involved in and very passionate about. This whole concept of is there miscommunication in families, and how does that affect pain and symptom management? And a lot of the ways that we cope with how we take care of our patients actually affect the way that patients take care of themselves. And so we give a lot of those cues to our patients, and they bring that up when they talk with our team, with other teams. In the research that I do, they talk a lot about their healthcare experience and how that affects their coping, and how their parents are able to provide the right type of care dependent on their coping. And so there are a lot of cues, a lot of hidden cues, and so it's so helpful for families to be able to clearly articulate what their experience is. And Dr. Sabnis, Animesh Sabnis, had also received some pilot funding to look at family meetings in the NICU and how important it is to communicate about goals of care in that setting, and is really doing great work there. We're also piloting a telehealth model so that way we can communicate with Santa Monica, UCLA, with telehealth monitor, and Don Panturo and Justin Steffens have been extremely helpful in that regard in getting that program up and running. And then we just found out that we have an approval to move forward with a proposal for mental health services in pediatric palliative care, and that's something that I'm working on right now because there's this scarcity of resources for kids, especially at home, who are immobile, and it's difficult for them to access mental health services in addition to the medical services that they need. We also collaborate with child life, social work, inpatient clinical psychology, psychiatry. The hospital has really taken off in this effort of improving quality of life. The urban Zen training that nurses can sign up for prepares them for CAM, a complementary and alternative, medicine therapies, so Reiki therapy, aromatherapy, gentle touch, all of these different things that Urban Zen provides. And Lori Baudino is a dance movement therapist who also can improve quality of life with a physician order, she's able to come in and provide that kind of work, and she's come to our team rounds and wants to continue to collaborate with us. And Heart Touch, which is a gentle massage. So I think it's important again to hear from Ashley's mom, because this is sort of the way that we've led our program, is listening to families, listening to the narratives of our families that we serve, and letting them lead the way, and providing the needs assessment that we need to construct our team.
She cared very much about people, humanity, and always wanting to help others. And she always thought about younger kids. Ashley's hospitalizations were in the pediatric unit. She would tell me how she felt really bad, how there were kids in the unit who didn't have family or people there with them 24/7. And it kind of made her feel really bad, because she's like, Mom, I'm so old and you and Dad are always here. You know, I feel bad for the other kids. Her best friend gave her a giraffe so that whenever she was alone, she didn't have to feel like she was alone, because she had her giraffe to be there with her. And I think for the kids who don't have somebody there all the time, something like that would be able to make them feel like they're not alone.
So again, it's letting our families lead the way in what the needs are. And with that comes our bereavement program. And Gina, who has been a wonderful ACGME program, filled this huge hole in our hospital system, provides
very much about people, humanity, and
provides resources to not only our families, but to our nursing team and to the staff at large, the faculty at large, house staff at large, in providing debriefings. At the time of death in the hospital, there's resources, and if we have more time at the end, we'd like Gina just to talk about that, because it's an awareness building opportunity. And an annual family memorial service that we started several years ago, and her bereavement group that meets twice a month and is open to all patients here, families of patients here at Mattel. And those are some pictures of the Comforting Hearts Family Bereavement Group, which is beautiful. And Gina gives us weekly updates on, and tries to update our staff and our faculty on how their patients are doing with the family's permission, because I think it's very important for our health and for continuity of care to know about these families and how they're coping with their illnesses. So I'm going to hand this over to Glen Komatsu to talk about how we partner with TrinityKids Care, talk about the philosophy of hospice, and this idea of continued palliative and supportive care in the home. And with this new bill that has been passed and implemented, this Concurrent Care and Waiver program that we worked so hard on for many years and now is actually a reality. And then how we help work with the UCLA primary team to facilitate that connection, but it can be done directly with the primary team and with Dr. Komatsu's group. So I just want to thank the following people. From our end, of all the people who supported our program and all of the grants and research and the family of donors who've really supported our program, and Glenn.
All right, so good morning. Have to say, it's pretty cool to be here. For a third generation Japanese American farm boy from Arizona, this is definitely one of the things on my bucket list, giving grand rounds at UCLA. So thanks to Elana for setting the stage. You pretty much understand now about palliative care. I'm just going to fill in a few gaps about the home program and what we can do. But before I start, I just want to make a couple of points that may seem obvious, but they're part of your reality. And the first thing is that no child or family comes to a place like UCLA for palliative care. They don't come here for pediatric hospice, right? You know, they're coming here for the cure. They're coming here for their miracle. So right off the bat, you know, palliative care is so countercultural to the general medical culture, but especially with children. And the second thing is that, you know, all of you who take care of seriously ill children or ill children in general are all doing palliative care. We in the field tend to focus on the subspecialty service, which of course is important, but all of you are doing palliative care. All of you are providing comfort and support to these children. And so it was great to see Elana talk about that, about incorporating sort of more robust palliative care principles into your individual practices. Because the point of our services is not to have every child who needs palliative care seen by a palliative care team. There's just too many of them, right? So we really want to encourage you, partner with you, teach you how you can incorporate some of these principles into your practice, because every child and every family deserves comfort and quality of life and pain and symptom management and better communication, whether they're going to get better or not. So TrinityKids Care started in 2001. It was a bold move on the part of our board to establish this program. There was no program in Los Angeles at that time. And in that discernment process, they realized that this was going to be hard. That first they had to find a team of pediatric professionals that would do the work when very little training was available. And the second thing is they had to commit to raising the money to fund this program. Because one of the main reasons you don't see more pediatric hospice programs around, even in the country, is because it makes no business sense. The cost of taking care of a child at home on hospice is more expensive than all the reimbursement, the per diem reimbursement schemes out there. So we get about $175 a day to take care of these children on hospice, and the average cost is about $205 to $210 per day. So that's why the Concurrent Care model, the waiver program are really important additions to our process. So I'm going to talk a little bit about those. So I came back from my fellowship in 2005, and we had an average daily census of around, I'd say 6 or 7 children on any given day. So today in 2015, we have an average daily census of almost 64 children. So really that's a tribute to the increase in awareness of hospice, but also to teams like yours here at UCLA who, referred children to our services. We have a great working relationship, for instance, with Noah and his solid tumor team. They have been huge supporters of us and really trusting us to take care of these children that they have worked so hard on for so many years, like Oscar, who you saw before. So these are the numbers of children that we've served. So it started out with about 30 in the first year, and now in the last 3 years, we're around 200. So you could say, wow, that's great growth. And it is in one sense, but really how many hundreds or probably thousands of children are out there that could benefit from hospice services in a city the size of Los Angeles especially. So these are the types of kids that we take care of. As you can imagine, the biggest slice of the pie is oncology, about 40%, and then a quarter are congenital anomalies, and another quarter are in the neurodegenerative sort of bucket, the Battens, Hunters, Hurlers, mitochondrial defects, all those things that I kind of heard about in med school and residency, but never really saw until I started this work. And then 8% is the miscellaneous categories with congenital hearts, cystic fibrosis, cerebral, things like that. I guess cerebral palsy is in the neurodegenerative bucket. So this is the size of our team. Really does take a village. So we have a manager, we have liaisons. The RN case managers are the leaders of our teams. They're the ones going out and seeing the children and their families on a weekly basis, and sometimes more often, supported by LVNs, 5 social workers, 2 chaplains, 1 home health aide, a volunteer coordinator who also coordinates our legacy art program. And we have a whole bereavement team that services both the adult hospice and the pediatric hospice, helping us with bereavement services for 13 months at least. We have an after-hours team to help us with triage and making after-hours visits with the children and communicating. So, and myself. So, fortunately, I'm getting a second doctor. I'm very excited about that in the next month. And so she's going to be working with us as well as Miller Children's. So these are the paradigm models. Elana has talked a lot about your team here. So I'm going to talk about the other 3 programs. So hospice is derived by from the same guidelines as government adult hospice, which is good and bad. The Medicare guidelines don't really fit pediatrics and pediatric diagnoses very well. You know, we have a lot of children with life-limiting or terminal illness, but the 6-month prognosis does not fit very well. So a good example is we get a child referred to us with trisomy 18. It's like, we know that child's not going to live a long time, but can we say they're going to die within 6 months? Especially if there's no congenital heart disease. So we've had those kids live as long as 18 months to 2 years. So we do need consent. There has to be certification of terminal illness by 2 doctors, somebody from your place and myself. And it's care delivered, as I mentioned, by that interdisciplinary team. And I already talked about the finances. All right, so a little known aspect of Obamacare that was slipped in is that the authors of that bill wanted children to be able to receive hospice services along with aggressive palliative services. What a novel idea. It's like, of course. You know, asking parents and children to give up their transfusions, their palliative chemotherapy or radiation, and go on to hospice exclusively, you know, is just not palatable for many families. So concurrent care is the use of hospice in the way that I just described, but the children can go back and forth to your clinics, back and forth to the hospital even, be hospitalized for up to 2 weeks, and still come back onto hospice services without being discharged. So Medi-Cal in California has agreed to pay for both the aggressive palliative treatments as well as hospice services. So the unfortunate thing is that only children that are eligible for Medi-Cal can receive this benefit. So if the child has private insurance, they can't get concurrent care. So this model makes total sense, right? Especially for children. But it really makes sense for adults too. And so now the adult hospice world and Centers for Medicare, Medicaid, they're looking at this model. And they're actually piloting, CMS is piloting some adult hospice studies, seeing how concurrent care can work for adults. Because adults don't want to give up transfusions and chemotherapy and radiation either. All right, one last word on the concurrent care is even though it's nationally, it's a national bill, that not every state Medicaid system has embraced it. So many states, they can't get concurrent care because Medicaid in that state has not agreed to fund both hospice and palliative care. So we're lucky in California that the legislature, the state health department, really has embraced this and given us the opportunity to demonstrate how effective it is. So the other thing progressive in California is that we have a waiver program. And this is, again, particular to California. There's a few waiver programs across the country, but we have one of the most robust models. And this is through CCS, as all of you know, it's California Children's Services. And this program provides in-home pediatric palliative care, which is coordinated by a CCS care coordinator. And again, only full scope Medi-Cal are eligible, children are eligible, and they do have a list of eligible conditions. So this is another helpful program. We have on any given day, about 50 to 60 children on the waiver. So we're doing the hospice program and we're doing the waiver program. So that staffing that you see, takes care of all those children. The other thing, these are the things that the waiver program provides: care coordination, expressive therapies, monthly nurse and social work visits, education, RN availability 24/7, and bereavement services. So under this model, I'm not involved. The medical teams here, for instance, are doing still the medical management of the child, and they drive the plan of care. The waiver program is there to support that plan of care as well as the children and their families. All right, so these are the programs side by side because there's a fair amount of confusion, but concurrent care is hospice and you have to have that 6-month prognosis. And partners, there is no prognosis time frame, but you have to have full scope Medi-Cal and you have to have one of the diseases on their list.